Let's talk about the clinical features, the signs and symptoms of acute myeloid leukemia. Since this is a proliferation of the blast cells generally replace the whole of the bone marrow. So they can basically kick out the normal erythrocytes developing, the normal platelets which are present there, and the normal white blood cells differentiated. So basically, all the types of cells, they are defective. The functioning of all the cells is affected. When the RBCs are affected, it will give rise to anemia. When the WBCs are affected, it gives rise to infections. And when the platelets are affected, it will give rise to the bleeding diathesis, the bruising. So the signs and symptoms of acute myeloid leukemia are non-specific. These symptoms can be present in a lot of other disorders as well. But I want you to understand the signs and symptoms. They arise because all the cell lineages have been affected, because the blast cells, they have basically taken control of the bone marrow, and they have kicked out all the other normal cells. So the other cell number will be down. The WBC number will be up because of an increased number of cells, but those cells are generally ineffective at performing their function. They are the malignant cells. So having this background in mind, the general signs and symptoms are the patient will present with fatigue or weakness. This is the most common presentation, and it is because of anemia. Anemia can be normocytic, or as we are going to see in the coming slides, it can be macrocytic as well if there is a folate deficiency. So fatigue is the major presentation. Around 70% of the patients, they will have an initial complaint of fatigue or a weakness. This is because of anemia or RBC disorder. Patient can also have anorexia, which can also lead to weight loss as well, since it is a malignancy. Fever is also a very common presentation. This is because of any underlying infection, because the WBCs are ineffective at performing their job. Although the number of the WBCs is high, but those are the malignant cells. They don't do their job well, which is protecting the body against infections. That's why the patient will have a fever. They will be bleeding. The bleeding will be superficial, which is a basically platelet bleed. The bleeding time can be raised as well. There is easy bruising, petechiae, which are classical for the platelet disorders. As you know that if there is a factor bleeding or factor disorder, the bleeding is generally deep. For example, hemarthrosis or the presentation will be like that. But here there are no factor abnormalities, since the factors are being made in the liver. The platelet bleeding can give rise to bruising. It can give rise to epistaxis and a superficial bleed generally. Similarly, there will be bone pain. Why will there be bone pain? This is important to understand. Since, as we said, that the blast cells are greater than 20% of the bone marrow, and eventually they will replace almost whole of the bone marrow when the disease progresses. So the bone marrow generally expands. The blast cells are larger as compared to the normal cells. So to accommodate those blast cells, the bone marrow expands, and that basically stretches the bone on both sides. And that's why the bone pain is a classical presenting feature of any hematological malignancy, be it the AML. It is interesting to note that in the previous times, when we did not have all these fancy tests, the peripheral blood smear or the bone marrow smear, how did the doctors diagnose the hematological malignancies? Well, they used to tap the sternum, they used to press the sternum, and if the sternum was painful, if this tapping or pressing the sternum was painful, then that was a classical sign for those doctors to identify that this is a hematological malignancy or bone marrow malignancy. So it's very fascinating, and it makes sense that the patient will have bone pains going forwards as the disease progresses. Similarly, the lymphadenopathy can develop. If the neoplastic cells go out into the blood, then they can also filter into the lymphoid tissue and reside into the lymphoid tissue. So there can be a generalized lymphadenopathy, but this will be a later presentation, and that's how we differentiate it from a lymphoma. In the lymphoma, the initial presentation will be a lymphoid mass. However, in case of leukemias or the WBC malignancy, the lymphadenopathy may or may not be present, and when it is present, it is a later presentation of the disease. There can also be a non-specific cough if the neoplastic cells involve the pulmonary system. So this may or may not be present. Similarly, if the neoplastic cells go into the CNS or the central nervous system, then we can have various neurological presentations like headache, certain cranial nerve deficits, or certain other neurological presentations. It can also present as a stroke as well. And diaphoresis if it involves the sweat glands or the skin. Certain types of AML, like the acute monocytic subtype, has a propensity to infiltrate the skin, so it can also involve the thermal tissue. It also has a propensity to involve the gums or the gingiva. So these were the major signs and symptoms of the clinical features of AML. The presentation is very non-specific. It can be very variable, and we have to rely upon our the age bracket, if the overall age bracket of the patient, and if he has any other precursor disorders, and then afterwards our various lab interpretations of the blood cells and the peripheral blood film and the bone marrow exam to make an overall picture and overall diagnosis.